under the leadership of respected Bhandari sir and Mehndi Ratta sir, and as always, Sajdev sir has been very affectionate throughout. I've also worked in Delhi at AIIMS Delhi, so we have a long association. And definitely, I have always appreciated since my MBBS days. We always used to look upwards towards Sir Gangaram Hospital as one of the most premium institutions in pediatrics and all faculties. So I feel honored to be chairing this session. Thank you so much, sir.
Dr. Amit Moon.
Thank you, sir. Thank you, Sachdeva sir, Alok sir, and Lalit sir for inviting me to chair this session. This is such an interesting topic. I think without wasting time, I'd like to invite our Dr. Manjari Agarwal, who is the moderator today.
Yeah. Dr. Manjari, you can take over now.
Thank you, sir. Thank you so much.
We welcome Dr. Manjari Agarwal, who has been the leader in pediatric rheumatology for so many years. We have been seeking so many help from so many patients, Welcome, Dr. Manjari.
It's always a pleasure. Thank you so much, sir. And I think we should have a meaningful discussion today. It's a very straightforward and a very simple case that we are going to present today. But it is one of the most common and challenging diagnoses that we often encounter. And it is more often missed than diagnosed. So we thought that we would, present the case, which looks pretty straightforward, but the discussion should encourage us all to think about the various differentials. So it's already 8:10, so I would request Dr. Purva to please start her case.
Good evening, everyone. Today I'll be presenting a case of a 3 year, 6 months old male who's resident in Rohtak, and the informant is mother. The child presented with the complaints of fever for 10 days, rashes on the face and trunk for 10 days, pain in both upper limbs and lower limbs for 10 days, and swelling in both wrists for 10 days. And now coming to the history of presenting illness, child was unwell from the January 2024 when he had fever for 20 days, which was maximum documented up to 102 degrees Fahrenheit, just quotidian and not associated with chills and rigor, relieved on taking medication, and child remained active in the interfebrile period. Fever was associated with the rash. Rash was erythematous, maculopapular over face, trunk, and non-pruritic, which heightens during fever and then fades away. Child also complained of pain in both upper limbs and lower limbs during febrile episode associated with difficulty in walking, and there was no diurnal variation, which also happened for 20 days. For which child was admitted in Rohtak from 24th of January to 5th of Feb. Investigations were done, which revealed raised inflammatory markers, and the child received IV antibiotics for it, but the fever still persisted, and the inflammatory markers remained high persistently, hence received IV steroids for that, and after that, symptoms got resolved. The child was discharged on oral steroid for 5 days and then stopped. Now, child remained apparently well for 2 months and now presented with 10 days history of similar episode of fever, maximum documented up to 102 degrees Fahrenheit, associated with maculopapular rash and pain in both upper limbs and lower limbs. This time, mother also noticed swelling in both wrists, which was acute in onset, gradually increased, and there was no postural or diurnal variation. Also, there was restriction of the range of movement of cervical spine during extension and lateral rotation for past 8 days.
So,
shall I proceed?
Before we go to the negative history, let's go back to the case and let's discuss it some more.
Yes.
So, you presented 2 separate episodes of fever.
Yes, ma'am.
So, they seem similar, but there's a little difference. So, the first episode was from end of December or early January, which lasted for about 3 weeks, right?
Yes, ma'am.
At that time, the child was evaluated and then given steroids. But
Yes.
as far as we understand, the patient did not know the diagnosis, and they were just given the steroids, but the family was not aware of any diagnosis, right?
Yes, ma'am.
Right. And at that time, did the child have any swelling?
No, ma'am. Parents didn't say they noticed any swelling.
They did not notice any swelling at that time.
Yes,
All
ma'am.
right. So at that time, something happened to the child, and then the child received steroids. And this time, when the child is presenting to us, the child has now, please come on to the slide where you have current problems. All right. So now when you're looking at this child at this point of time with this past history, what is the thing that comes to your mind? What would you, which involvement would you think of first? Not diagnosis. What would you think of first? Suppose you're sitting in the casualty and this patient comes to you, or you're a medical officer, you're sitting and you are, you have to send this patient to somebody. So where would you direct this patient to? What would you first think of?
Ma'am, because of the swelling, mostly I'll consider rheumatological.
Okay, very good. So because the child now has a swelling of both the wrists, you would think of rheumatology, right? And also the cervical spine involvement, you would think that, okay, there's something wrong with the joints. Would you not consider orthopedics in this case? Would you not think of a septic arthritis for the wrists and see if because there is fever for 10 days and there is swelling of the wrist? Would you think of septic arthritis? Why or why not?
In septic arthritis, mostly a single joint would be involved firstly, and the joint will be tender and mostly, and because of the past history also, there was similar history which is resolved on steroids. It is most likely it is not septic arthritis.
Very good. So a very, very important, well brought out point that in a septic arthritis, typically it would be a single swollen joint, which would exhibit all the classical features of inflammation, which would be a red, hot, swollen joint. And that is how we identify a septic joint versus a joint which is chronically swollen, like in a juvenile idiopathic arthritis or in other arthritis of childhood. So that gives us a little clue that this is not septic. Now, suppose the child did not have the swelling of the wrist or did not have the cervical spine movement restriction, but had only pain, like how the child had earlier.
Yes,
In that case, what you would have thought of? What would you be thinking of? A bit more other than rheumatology?
Then infectious causes, I will rule out if there be only fever, rash and pain, any viral illness, any bacterial illness, or there could be TB also. If
The
it's
rash?
not with rash, only
Right. Anything else?
and there could be Kawasaki disease.
Okay. So predominantly you would think of very good infections, especially viral illnesses associated with a fever and a rash, with arthralgias and myalgias. That's the first differential that you would be considering. With just this knowledge, just this very well taken history, where you have similar episodes of fever and with the maculopapular rash. And just go back to your slide. I just wanted to discuss a bit about the rash over here. Yeah. So now let's talk about this rash. So one thing that, or first finish the fever. So one thing that you've written in the fever, which is very interesting, is this is called as, what you've written something called as quotidian. So what do you mean by that?
Yes, ma'am. It's a type of remittent fever only, which occurs daily. There's a rise of temperature and which comes to normal range after a peak. It touches baseline.
Quotidian classically means that the fever spike comes down, touches the baseline, may even go below baseline, and occurs at least once a day. Right?
Yes,
so that's quotidian, which would occur at least once a day. And then there's a second thing that you've mentioned, the child remains active in interfebrile period. Now, this is something that you would not see in a patient of Kawasaki disease. In a child with Kawasaki disease, the fever would not touch the baseline, would not go below the baseline. It would be a continuous fever. And the child would be cranky, irritable, and not well. Even if the fever subsides with anything, the child would not be well. So that is a very important differentiator. And that is why when the child was unwell in the first episode, we were not thinking about Kawasaki even in that episode. Even if the child did not have any swollen joint, we think that the disease was just progressing and the progression was just halted by the steroids that the child was started on. Right.
Mm.
So then, similarly, in similar vein, if you look at a child who's got TB, or if you look at a child who's got a viral illness, these are, at 20 days, they are sick children. I mean, first of all, the viral illness won't last for this long without any other feature that, the parents would have noticed. But even then, so as you go, there are very few causes of fever in childhood. And when we talk about fever, then we need to understand that as we keep going away from the onset of fever and the fever persists, the causes of fever, the infectious causes of fever keep on decreasing. And the other things come into play. The other things may be malignancies, the other things may be autoimmune, or the other things may be some infection due to an underlying inborn error of immunity, which was up until now called as primary immunodeficiency. But here the child did not have any other feature which could suggest that the child had any infection. Right. So now let's look at the rash. So you say that this rash is erythematous, maculopapular over face and trunk, non-pruritic, heightens during fever and then fades away. Can you let me know any differential for such type of a rash?
No, ma'am. This is classical of systemic JIA only, which evanescent rash, which we call, which occurs during fever and then fades away.
Yeah, and where would you typically find this rash? Here, this child had it over the face and the trunk, but where do you typically find it?
Ma'am, mostly in the hidden areas, like under the clothes and trunk areas, wherever the creases are there.
No. So the warm and moist areas of the body, like the axillae, the medial part of the thighs, over the limbs. And yes, what you're saying, the creases of the clothes may be seen on the child. That's a phenomena called as Kobner's phenomena, where in that case we see, the child's skin exhibits the triple wheel response, so that if you were to strike the child's skin, there would be a reaction. It would turn red. It would be elevated. So it's called as a triple wheel reaction. So that is something which is called as a Kobner's phenomenon. It is very well seen that these children would have all their clothes and all, and then you can see the creases, or you can see, sometimes tiny even petechiae around these. But that is a Kobner's phenomena. And this rash is, sometimes it is missed. And a rash is not a sine qua non of systemic JIA, and may be absent in up to 30-40% patients of systemic JIA. So the rash, if it is present, gives us more confidence to make the diagnosis. And we do not hunt usually more. Like in this case, it was pretty straightforward. And the father was even carrying some pictures from the previous episode when the child was admitted when he was getting the rash. And in this episode also, and the father recognized that this is the same type of fever. And that's why this time he just didn't bother to go to that place and came here. So here, in this case, the non-pruritic nature, the evanescent nature. So evanescent means which would come and go, which would come and disappear. The non-pruritic nature, the evanescent nature of the rash would give you a clue towards the diagnosis. And as you're rightly pointing out, this specific type of a rash typically does not have a differential and is classically seen in a case of systemic JIA, which this child seems to be suffering from. Right, so carry on.
Now coming to the negative history, there's no history of night awakening. This is to rule out any malignancy. There's no history of weight loss or chronic cough to rule out TB. There's no history of mosquito bite and node bite or recent travel to rule out any viral infection or any rickettsial infection. There's no history of redness of eyes, redness of tongue, cracking of lips or oral mucosa, peeling of skin or erythema in extremities. This is to rule out Kawasaki disease. There's no history of any swelling in neck to rule out any lymphadenopathy. There's no history of swallowing difficulty, cough, runny nose to rule out any upper respiratory tract infection. There is no history of loose stool, cry or pain or burning sensation during micturition, pain, abdomen or vomiting to rule on any gastrointestinal infection or urinary tract infection. And there's no past history of similar illness or admission.
Right. So basically, most of your negative history is pertaining to if in case this is a second episode or, if this is a different episode. So basically, you're just trying to understand that whether these are both related or whether these are both unrelated episodes, which could happen. I mean, if a child has got systemic GI, that does not prevent the child from having Kawasaki disease now, or that does not prevent the child from catching an EBV infection or from getting any other viral infection and landing up into trouble. So this is very important to find out from the parents about any obvious lumps or bumps, about any night awakening, or about any TB can occur to anybody at any point of time. This child was given steroids, and we did not have, the family was not carrying any papers. We did not know what doses of steroid the child had received over a period of whatever 7-8 days or 13 days. So that was also, all of this becomes very, very pertinent in your case. All right, proceed, please.
Family history: child is born of non-consanguineous marriage. There's no family history of TB or Enk's spondylitis, IBD or psoriasis. The child has one elder sister who is 16-year-old. Birth history is not significant. Child born by normal vaginal delivery. As per gestational age, there is no NICU admission. Birth weight was 3 kg. Development history: child attained age-appropriate developmental milestones. Immunization history: immunization card was not bought, but parents said that they completed immunization under a government program and received last immunization at 18 months of age. The child tolerated all the vaccinations well.
So why do you think this immunization history was important here? I know it's to complete the list, but still.
Yes, ma'am. Because there are certain vaccination which can lead to some rheumatological diseases, since the child didn't receive any recent vaccination. So it was not
unlikely. Right. And what about tolerating all the vaccines well?
Yes, ma'am. There was no reaction after, no adverse effect after vaccination. It occurs after MMR vaccinations. There was no reaction which can trigger few rheumatological conditions.
No, and also very important, always remember, if a child does not tolerate the vaccines well, or if you have any adverse event, in an illness after a vaccination, then you also need to evaluate the immune system very, very carefully. And in fact, children, those who have an underlying immune error of immunity may do this and may also have another autoimmune condition in the offing. So to say that you need to take this history very carefully, and the parents then remember whether the child had any serious reaction to any of the vaccines or not, or developed any vaccine preventable disease or not. So that is important, and that just gives you a little question can give you a huge clue towards your diagnosis. All right, carry on, please.
Dietary history: child was started with breastfeeding after birth, and complementary feeding was started 6 months of the age. Child is pure vegetarian. This is the 24-hour dietary recall. So according to it, the child has taken around 1,000 kilocalorie and 24 grams protein, and the calorie deficit came out to be 170 kilocalorie, and the protein was adequate. Coming to socioeconomic history, the child belonged to upper middle class family according to modified Kupuswamy scale. Now coming to summary, according to the clinical history, a 3-year, 6-month-old male, second born to non-consanguineous parents with normal birth and developmental history, with history of admission in January, with complaints of fever, rash, and pain in upper and lower limbs for 20 days, and found to have raised inflammatory markers which resolved after taking steroids. Now presented with a history of fever for 10 days associated with rash, pain in upper limb and lower limb, with bilateral wrist swelling and restriction of the range of movement of the cervical joint, which aggravates during febrile episode. So the most probable diagnosis, according to the clinical history, is systemic juvenile idiopathic arthritis.
Very good. So we've already discussed all of this, so we can proceed further.
Now coming to general physical examination, the child was febrile, and during the admission, it was 101 degree Fahrenheit. Restral examination was normal, and the pallor was also present. There was no icterus, clubbing, cyanosis, or lymphadenopathy. Now coming to head to toe examination, in this on face, maculopapular rashes were present, and on skin, also rashes were present in the anterior chest wall and back. Coming to anthropometry, height was 13.7 kg, weight 13.7 kg, height 99 centimeter. And according to WHO growth charts, there was no malnutrition. Weight for age was 0 to -2 standard deviation. Length for height for age was 0 to -2 standard deviation. BMI comes under -1 to -2 standard deviation. Now coming to musculoskeletal examination. So according to pediatric gait, arms, legs, and spine examination was done. The gait was normal. There was no deformity. Bilateral wrist swelling was present. There was no erythema or warmth. And during flexion and extension, tenderness was present. Bilateral knee, there was no effusion. Cross fluctuation test was negative. And cervical spine range of motion decreased on extension and lateral rotation. Rest all joints were normal and rest of spine was normal. But abdomen was not distended, no scars, no dilated veins. Superficially, there was no local rise of temperature and no tenderness. On deep palpation, liver was palpable 2 centimeters below right costal margin, was non-tender, smooth, and had rounded margins. Spleen was not palpable, and on percussion, liver span came out to be 11 centimeters. Rest all examination were normal. Now, the summary after examination. On examination, child had found to be pallor, maculopapular rashes, bilateral wrist swelling and tenderness, along with restriction of cervical spine, range of movement, and hepatomegaly was present. So, according to the International League of Association of Rheumatology, the child has arthritis in one or more joints with age less than 16 years. The onset was more than 6 weeks, and the fever of at least 2 weeks or longer, with documented to be at least daily for 3 days, and accompanied by one or more of the following: evanescent erythematous rash, generalized lymph node enlargement, hepatomegaly and/or splenomegaly, and fourth is serositis. So among this, 2 were present. So our diagnosis came out to be systemic juvenile idiopathic arthritis.
Right. So I would just stop you here for a minute. And when you were saying about the Euler definition, so what are these? So what are Euler classification or work criteria? What are these criteria?
Ma'am, this is criteria for idiopathic arthritis. So
no. What are these criteria as in? Are they essential for a diagnosis or for what? What is the purpose of these criteria?
Yes, ma'am, for diagnosis and classification of different types of JIA.
So no, so these criteria are not meant for diagnosis. They are not diagnostic criteria. These are classification criteria. And the whole idea was that when people across the world were looking after these children and they were trying to compare their stories, their data, they were not able to do so because what I was calling as JIA, somebody else was calling as JRA, and somebody else was calling as JCA, and somebody else wanted to give it a different name. And then everybody were using different terminologies for either the same disease or same terminology for different diseases, which was crazy. So that is why the International League of Association of Rheumatology decided to give the classification criteria a uniform classification criteria. And as far as the clinical diagnosis is concerned, it's the clinical judgment, and that is why we say that there is no one test to rule in or rule out the systemic JIA or any other JIA for that matter. And in this, yes, this child here, we were fortunate enough that this child had this classical rash, this child had a hepatomegaly, because more often than not, we just see a generalized lymph node enlargement, which could be there in any children post a viral or post a bacterial sore throat infection. as many of the clinicians here must have seen routinely, and the fever, which may be about 10-12 days. So every fever of 10-12 days, there might have been some rash which nobody had documented, or there might have been some rash which was part of a EBV like virus or a strep or something, and there may be a hepatosplenomegaly. So would that mean that the child has got a systemic GIA? Then our OPD would be chock-a-block and we would be seeing so many children. Oh my God! But that's not the case. So what happens is that in a clinical context, when you are seeing, then you try to put fix this classification criteria and they would help you. But if you're not able to fulfill any of these, but you feel that yes, this is a systemic GIA because the fever pattern looks like that, because so it is a pattern in which you have to fit your particular child into that clinical pattern. So the clinical pattern would be of a child who presents to you with an age of less than 16 years, would have a long history, the fever out of which should be of at least 2 weeks. Out of these, 3 days at least should be continuous, a daily. And then you may or may not have rash. But if you have only arthritis and the fever, the arthritis lasting for more than 6 weeks, then yes, you are more or less sure. The rash gives you more confidence. In association with the arthritis and the rash, like for this child in the second episode, we were pretty confident. One look at the child, it was like a spotter. The child was not able to move the neck. He was febrile. He was irritable at that time. And after 3-4 hours, when I went to the ward, and the child had not even received the steroids till then, and we went to the ward to look at the child again, and he was a different kid already. There was no rash, and the child's neck was also, he had difficulty, but it was slightly better. The movements were slightly better. So this gives us a clinical clue. And even without knowing the investigations, we are pretty confident that yes, we are dealing with a child of just put my point across that the IAP classification criteria are classification criteria, and by no means are they used in a daily clinical practice for diagnostic purposes. All right, so let's move on.
Sorry, can I interrupt for a second here?
Absolutely, sir.
Apurva, when you are doing it in the examination, when you are presenting a case in an examination, you can't say that this is the diagnosis. You have to give a differential. I know you discussed the differential when you finish your history of the present illness history, but after your physical and all, you have to still give a differential diagnosis, with the topmost one being the most probable diagnosis. And then when you are talking to the examiner, you may put in points that you feel this is the topmost reason because of the following reasons, and you feel the second one is not that possible because of these reasons. So that is how you have to present it in an examination, not just giving a diagnosis. I know the diagnosis is correct. The examiner also knows the diagnosis is correct. But what is important is that you are able to elicit to the examiner that what was the process of what were the thought processes which led you to come to that diagnosis, and what was your differential diagnosis which you ruled out in the process. So that is very, very important, because nobody is looking at the diagnosis. Your process of reaching a diagnosis is more important than the diagnosis. Okay?
And one more thing I would like to add here, in examination, did you tell about the sternal tenderness or bleeding spots? Eye examination, what is the importance of all these things?
Yes.
Or do you think some other connective tissue disorders, or some it is related to post-viral kind of a miscellaneous syndromes which we had, that inflammatory syndromes? Could this be also a possibility? Because this is like a tailor-made, the person knows the diagnosis. I think differentials are very, very important, Dr. Anupam has said. And eye examination is important, and sternal tenderness and the bleeding spots. What is the importance of those things? If you're Purva, you can say those things in differential. If you think the child has sternal tenderness, what else you can think of?
Sir, other connective tissue disorders could be there, and sir, an eye examination also, if there's conjunctivitis, it could
No.
be covered and uveitis.
Can you say something in specific to eye, examining the eye in relation to that? Not for conjunctivitis. You want to see something in, can there be some involvement in joint involvement with the eyes?
Uveitis. Like in oligoarticular JIA, we have to look if there's uveitis. So we'll see if there's a red pupils. If there's
the importance of bleeding spots and sternal tenderness.
Anyway, you will not get that in a normal eye examination. You have to go in for a specialized eye examination to look at uveitis. You may miss it totally.
Yes, sir.
And any thinking of possibility of malignancy?
Yes, sir. For that, we'll look out any petechiae to rule out any malignancy.
Yes, yes. So this is what Dr. Ankur was saying. You should not tailor-made the diagnosis. You should always come with differential, because your examination should always rule out something, sir, because there is no other bleeding spots, bony tenderness, and malignancy will not last for this stage. So these are the other differentials. You can say other connective tissue disorder, or this could be a post-viral inflammatory syndromes, right? In which this all hepatomegaly, splenomegaly with fever persisting. Of course, we will confirm it with the investigation. This was my point. Dr. Manjari, you want to say something?
No, absolutely right, sir. Actually, that's what we thought, that the way to go about, we had because this child, we could have presented it like how sir says, and it is a very well taken time that we should put in the differentials over here. And but we thought that we would discuss it along with the history, that because this case here had the classical rash. So we were not even thinking, although the child was examined for all of this, was looked for any other rash, was looked for petechiae and for sternal tenderness. But definitely we want to, understand, Apurva should have mentioned, and it's a point well taken, that we would be including the differentials. And your comment, Dr. Nagrata, was very good about the, post-viral, those inflammatory syndromes that we were looking at, and they also presented somewhat like this. And in fact, the episodes would have been like that, but then because this was the second episode of the similar illness, that's why we did not. If this would have been the first episode with us, and we would have seen the child in the first episode, then yes, the differentials were wide open over here. We would have, in the absence of involved joints and with a short history, we would have also thought of viral illnesses. We would have evaluated the child for a malignancy as well. And we would have evaluated the child for tuberculosis as well, which in any case we would be doing. Even in this case, even if we diagnose any child with an autoimmune condition, we do evaluate them for a possible underlying tuberculosis. And we do look for any very common viral illnesses which may be there, or the history pertaining to those. And but if the rash was absent and we would have had only fever, and if the joints were just coming and going and not a fixed arthritis, then even we might have proceeded to do a bone marrow before throwing steroid at the child. So that is again, and I think I had planned to discuss all of these points in the subsequent slides when we had some investigations as well.
This is just from the PG's perspective, basically.
Absolutely.
Thank you. I think you can proceed now.
Now coming to the investigations, these are the serial-wise investigation. First, from the January till the last here, hemoglobin was persistently low. Initially, it was 9.1. Now came to 7.8. TLC was initially it was 13,000 with neutrophilic predominance. Now it is 18,000 with neutrophilic predominance. Platelet was mostly high. It was 5,51,000 initially. Now it came out to 5,87,000. CRP initially was 6. Now it is come out to be 172. And these are the investigations here. BUN, creatine, AST, ALP were normal. ESR was elevated, 91 mm. Serum ferritin was normal, 277. CPK to rule out any myositis because child had pain. Blood culture was normal. Urine routine microscopy came out to be within normal limit.
Right. If the child did not have any joint swelling, but the child had fever and the child had rash. It may be vanicilled, it may not be vanicilled. What other connective tissue disease would you have thought of in this age? Is it fever and rash? I'm saying which rash. I'm not defining the rash. I'm just saying fever with rash. Which other connective tissue disease other than I'm not talking about vasculitis. So I'm not talking about Kawasaki disease. And the child had pain in the joints and muscles. Have given you a huge clue here. No? Would you be thinking of juvenile? Something to do with the skin and the muscle?
Okay, ma'am. Dermatomyositis.
Juvenile dermatomyositis. And sorry about that. So sometimes in juvenile dermatomyositis, you may find these small children. Otherwise, majority of the connective tissue disorders are seen in older children. They're slightly older children. In children who are typically beyond 7-8 years of age, you would find lupus or you would find other connective tissue disorders of systemic sclerosis, etc. Juvenile dermatomyositis is one disorder which has a bimodal presentation like a systemic JIA. The systemic JIA also typically has a bimodal presentation where you may find the children to be preschoolers. They are usually, for children to be under 1 is slightly unusual, but we do see them at under 1 year also. But most often they are in between 1 and 4 years of age. And they begin with fevers and they begin with hectic fevers and very well in afebrile period. They are active, they would run around, they would eat well during the afebrile period, and then they may or may not have the rash, they may or may not have the lymph nodes, and they may or may not have any other problems, and then they may develop some joint involvement. So these are the classical presentation, or they may be older children beyond 10 years of age who may present to us with fevers, and then we make the diagnosis. And it is the older children which tend to run into difficulty much more common, with macrophage activation syndrome being much more common in the older children or in very young children. And that is where we would typically see the hyperferritinemias and the other illnesses. We may have a viral trigger or some history. We may have a viral trigger. There is no There's a patient who's trying to connect. So this is what we would see. So if you have a smaller child, otherwise you would not be looking at any other connective tissue disorders in a child who's presenting to you fever and a rash. And again, if we take out the rash from here, then the differential is huge and widely open. And if we had only the fever and we had only the arthralgia and myalgia, then what would have been your first differential?
Yes, ma'am. Only fever with arthralgia could be any infection, any viral infection, like EBV, chikungunya, dengue.
Anything. Yes. Anything. It could be anything. So then it's very, very difficult. So what happens is, when we are looking at children who do not classically have the joints or the rash, then we use the labs and the labs come to our rescue. Because otherwise it's a dictum in rheumatology. We say that 85% of your diagnosis comes from the history, a well-taken history, about 10% from your examination, and the remaining whatever is there from the labs. But when we do not have a classical history, or when the parents are sometimes not able to give us a very good history, sometimes we may not have a reliable historian, or sometimes if it's a very long history, and they may not even, give it properly. So then in that case, we come to the labs. So let's look at the labs over here. Let's go to the labs. And I know that this may not be a part of the exam, but from a practice perspective, so I thought that we would include the lab slide over here so that we can discuss the slight nuances and understand how to differentiate. And suppose the age was different than what we would have thought of. So please go back to your lab slide. Right. So now over here, if we look, now we have the investigations of the January episode. When the child's hemoglobin was 9.1, the counts are high with 84%. Suppose this was reversed. Suppose, Apurva, the neutrophils were 9% and the lymphos were 84%. What would you have thought of?
It could be any viral infection if lymphocytes are
84% lymphocyte?
malignancy.
Yes. So you would have first suspected of a malignancy over there. You would have immediately asked for a peripheral smear. So that is something even with normal platelets, although in a malignancy, the platelets would be low, but even with normal platelets, we've seen children with ALL with even 3.5 lakh platelet count. So the platelets may take their own sweet time to go down, but the lymphocytosis is pretty marked. So a reversal of count, but not in this age, but still to this extent, is definitely a pointer towards the malignancy. Because sometimes you may not find terminal tenderness. Sometimes they may not be night awakening. They may be giving paracetamol for all that you know. Sometimes they may be giving, flexons to the children, and they may not have night awakening. They may, or somebody might have helpfully given them some steroids also on the way. Some deflazacort. It's very fashionable, in remote areas to give these drugs to children, and they may mask the problem. So there the labs come to our rescue. And I think the child must have been very sick around the 2nd of February. I don't like the counts falling. So a falling platelet count is a problem. A falling hemoglobin is a problem. The CRP was rising, and then the child must have received the steroids, after which everything must have calmed down. Unfortunately, we don't have any bloods. And now in this episode, again, when we look at the bloods, the hemoglobin has not recovered. The counts are high and the platelets are also high. So this is something that you would classically see in a systemic JIA. Now, suppose this was a 10-year-old girl and she presented to you with similar counts, then what you would have thought of?
SLE.
No, I wanted you to say that. I wanted to test you. Okay. So no, this still would not be SLE. Why? Why would this not be SLE? And you know the answer. Tell me why. With a 16,000 count, SLE? So what would happen in SLE to the counts? So remember, in systemic JIA, your HB would go down, but all other things would go up. Your TLC, your platelets, your ESR, your CRP, everything would go up. Versus in a lupus patient, here in a 3-year-old, you're actually not thinking about lupus. But suppose this was a 13-year-old, 10-year-old, 9-year-old, 8-year-old, and you were thinking about lupus. In that case, the counts would have been low. So what happens in lupus? The HB goes down, the TLC goes down, the platelets go down, the ESR goes up, and the CRP goes down. So paradoxically, in a lupus patient, the CRP is low and the ESR is high. And the reason for this is not very well understood, but probably lupus is a predominantly B-cell disease, and that is why the CRP doesn't rise very frequently, but still. So now, if this was a systemic JIA only, and the HB was low, the counts was low, the platelets was low, the ESR was low, and the CRP was high, what would you think of?
Macrophage activation syndrome.
Very good. So always remember that. Always remember that. In a child with, and that's a big problem. In fact, currently we have a patient in the ICU where we saw that the child had severe rash all over the body, a fixed rash, and then the child was running fever and had swollen joints, and the counts were low, the platelets were low, everything were low. So what do we understand from that? That macrophage activation syndrome happens in an already diagnosed child. It is very easily picked up because the child already has a diagnosis of systemic GIE, and you anticipate that this child may get macrophage activation syndrome at any point of time. But in a child who is never diagnosed before and presents to you with a macrophage activation syndrome, it is very difficult to diagnose unless they have joined. So if a child presents to you with only fever and a fixed rash, because the rash of macrophage activation syndrome is not evanescent. And this is another learning point, that if you have a child with systemic JIA and the child rash goes away, But now suppose the same child of systemic GI, now suppose this old same 3.5-year-old child starts running high-grade fever spikes continuously, like every 6 hours, every 8 hours, and the count start to fall, the ESR starts to fall, the ferritin starts to go up, the CRP remains there where it is, and the rash becomes fixed. There, in that case, you would understand that the child is running into difficulty and the child has got macrophage activation syndrome. And the identification of macrophage activation syndrome is absolutely critical. And we don't have time to waste, and the child requires high-dose methyl prednisolone intravenously. So that is the learning point from here. So this is where the
Can I
labs
come in? So,
come to our
yeah, Manjari, can I
Sure.
come in? This, see,
Sure.
it is very important to differentiate, because macrophage activation syndrome from a malignancy, because
Yes.
in all these conditions, whether it's malignancy or macrophage activation syndrome, the presentation could be fever, it could be pancytopenia, it could be thrombocytopenia, alone leukopenia, all these things. So when you get a patient who is a suspected SLE or suspected juvenile rheumatoid arthritis or anything of that sort, even if it is labeled and even if it is diagnosed, if you get a fall, you must rule out malignancy in these cases.
True, sir. Because and also
And the
they
reason,
do exist.
when I used to say this thing that if you get macrophage activation syndrome in a patient of SLE or something of that sort, the ESR falls. The reason is that the fibrinogen levels of the body fall, and that leads to a fall of ESR. So it's very, again, a fall in ESR would lead you to send the fibrinogen levels also, so that you can easily diagnose it. Thank you.
Absolutely. And in fact, sir, we teach all the students that the ESR is a poor man's fibrinogen level. So if you don't want to spend a lot of money doing fibrinogen for the patient, you can just look at the trend of the ESR, because ESR ultimately is a marker for fibrinogen. And fibrinogen is the main thing that contributes to the erythrocyte sedimentation rate. So it would be, but absolutely, sir, the fall, and in fact, out of, I think, if we see 10 macrophage activation syndromes at presentation, then 9 of them would undergo a bone marrow to rule out a malignancy. And now we can even put markers to identify whether what is the activation, and we can even get the histiocytes, and we can see the hemophagocytosis, which makes the diagnosis much more easier. So, point well taken that the bone marrow examination becomes very pertinent, and especially if they're undiagnosed. If they're diagnosed cases, then sometimes we tend to not do the marrow if we are very sure about the diagnosis. If the ferritins are very high, and if we are seeing that the platelets are falling rapidly, then we may go ahead and give the pulse of steroid without doing a marrow. But if they are undiagnosed children, if they do not have a diagnosis at hand, then certainly a marrow is warranted in these cases before giving them steroids, before giving them high-dose steroids, even after, in that case. Right. So I guess, Apurva, we came to the end of our presentation.
Yes, ma'am. Treatment. The child received pulse dose methylpred for 3 days, and after first dose of prednisolone, symptoms resolved. Child was discharged on oral prednisolone, 2 mg per kg per day, with advice to follow.
Right. Great. Thank you so much. So that was well done, and I hope you've learned all the things that we were taught today. So about the addition of the differences over there.
Yeah, comments from Dr. Mishra and Dr. Mohan. Dr. Mishra?
Yes, sir.
Your comments and
So, very, very classical case, and great discussion towards the end, and leads by you and madam as well. So very pertinent to rule out malignancies, as I was just thinking over then. The incidence has been on a rise. Plus, collagen vascular disorders are always a bit of a, they are like a surprise box most of the times, and lot of overlapping diagnosis. So basically, lab, the criteria as well as the lab backup plus expertise go a long way in diagnosing and managing these patients. So happy to be a part of it. A privilege. Thank you, sir.
Dr. Amit Moon. Dr.
Sir,
Amit, kindly
hello,
unmute yourself.
sir. Thank you. Thank you, sir. Thank you. It was such a good learning experience, and everyone was so good. Dr. Apurva's presentation was so good, and the moderator, madam, who took us stepwise towards the diagnosis. Deva sir, your expert advices. Excellent presentation. Thank you, sir, for inviting me. I'm in a family function here, so
I know that you told me that you
excuse
may have to.
myself. I'll excuse myself, sir. Thank you very
Thank
much
you
for
very much, sir. Thank you very much for taking out time. Dr. Lalit, would you like to thank everybody?
Yes, really, the Purva presented well with, I think, emphasis for postgraduate is always on differential diagnosis. It should not be a tailor-made, you know, everything, the diagnosis, and you tailor-made the history accordingly. Don't make tailor-made history. Always go think beyond the common diagnosis. That's how we learn. You know, PG learning is always the differential. And that differential will come only when the mind will start thinking about those things. And of course, we should always investigate these kind of patients, you know. It's a kind of a fever, prolonged fever, so needs to be worked up properly, like Mandri said. And you did not mention about the peripheral smear part and rheumatoid factors and other antibody factors which were done in this case. Peripheral smear examination and RF factor, was it done in this?
Yes,
Not mentioned.
peripheral smear examination was
You
done.
did not mention about, I think, peripheral smear. That is an important part, and rheumatoid factor, you know, was positive or negative. These are things. Anyway, otherwise, it's always a good learning. Dr. Manjari, nicely taken up. And Dr. Bhandari sir?
No, it is really good to revise your old things, which we read very rarely. And I'm thankful to Dr. Manjari also for taking it up in a very nice manner. And Rakesh Mishra also summed up very nice with very nice comments. I think it's really nice feeling. Everybody must be going much more knowledgeable after this 1 hour of
definitely
brainstorming. Rakeshji, what do you say?
Oh, definitely. I was so spellbound with all the comments from Manjri ma'am and Sajdev sir. So I myself, it was a great learning experience for me as well. Thank you so much.
Thank you very much, all of you.
Thank you. Thank you.
And good night, sir. Good night,
Good
Dr.
night.
Alok. Good night,
Good night, sir.
Amit.
Good night,
Good
dear.
night.
Thank
Thank
you.
you, Bhandari sir and Mehndi Ratta sir.
Good night. Good night.